Hello everyone and welcome to our webinar. Today's subject, the bottom line for compliant reimbursement, physician documentation, getting the devil out of the details. My name's Chuck Buck, I'm the publisher of RAC Monitor, and it's my pleasure to be your moderator today. So let's begin. Today as never before, physician documentation is a critical component for dodging the barrage of RAC audits being directed at your facility, and even determining your success or failure in surviving healthcare reform, parts of which coincidentally take effect today. For whatever reason, the lack of clear, appropriate documentation on the part of physicians remains one of the most prevalent causes for denial of inpatient reimbursement. We all know that the devil is in the details, but do physicians? And how can you help physicians in your facility cope with the new demands of providing clear and appropriate documentation in the medical record? Well, you're about to hear an extraordinary presentation from a nationally known physician responsible for advancing clinical documentation with his peers and hospital organizations. He has a keen appreciation for how to address the devilish details needed for documentation improvement. Please welcome, if you will, Dr. Robert S. Gold, MD, co-founder and CEO of DCBA, Inc., a consulting firm that concentrates on the development of clinical documentation improvement programs. And joining Dr. Gold is a familiar voice to many of you, Patricia Deer, a registered nurse with more than 30 years of experience in healthcare who works within corporate healthcare entities, for-profit and nonprofit hospital systems, legal defense, and plaintiff counsel. She is a recognized national speaker on reimbursement and compliance, and she is the president and CEO of EduTrack. So now, without any further delay, I'd like to turn the program over to Patricia Deer. Pat, the screen is all yours.
Now, one of the most contentious issues, which most of us have been just waiting with bated breath for the other shoe to drop, if you will, happened as of September 10th. All 4 of the RACs have now been approved by CMS to wade into the medical necessity waters. In other words, does the physician documentation, does the medical record substantiate that the level of care delivered on an inpatient basis, in fact, meets the medical necessity requirements that it should have been paid for? And upon the verification of that information, there in fact is enough information in that record to say, yes, indeed, we have a medically necessary length of stay where the physician has documented the hospital record is complete and the payment should have been at the DRG assigned. What is of interest is all 4 RACs added 29 new MSDRGs. I've only highlighted in green on this slide some of those that were new, and the first grouping, that being chest pain, heart failure, and syncope. We want to ask the question about those pesky little one-day stays. Should it be an observation outpatient? Should it be an inpatient? There we go. There's the first grouping where, in fact, statistically, the RACs know this is a home run for them. That has been an area of question, and certainly we anticipate that there will be a lot of aggressive movement. We've been hearing from clients across the country. Several of the RACs here in the southeast have seen the maximum number of records being able to be requested at one time. Other systems are seeing small handfuls, but they're seeing small handfuls with 80% coming back quickly as being denied. So I would suggest to you and your RAC teams that, in fact, the issue is now on the table. Make certain that you review those records beforehand. To a large degree, this is past event. So as Dr. Gold starts to speak to you in just a moment or two, it's important to know what we cannot change about the past, but how we have to draw the line in the sand and move forward. Move forward with process change, move forward with, one hopes, physician embracing.
Well, sometimes docs get into trouble. I know that a plastic surgeon that I knew a number of years ago had gone to a meeting of plastic surgeons where he learned that if he used certain different terminology for a rotation of a flap, he was actually not rotating a flap. He was just advancing the edges of the wound prior to closing it to take off tension. And so they learned, use the term flap rotation and you can bill a higher level. Well, he thought that was really cool, and he thought that this was something that was out there and everybody was supposed to do it, so he started doing it. And then some insurance company found out that he was doing it, took a look at what he actually was performing, found out that he wasn't doing a rotation of a flap, and they took a lot of money back from him, and he didn't like it. One of the hospitals that I went to encouraged their surgeons to use a short form for outpatient surgery, and then they admitted the patient after the outpatient surgery. Well, the doc thought this was cool. I can use a short form. I don't have to work as hard. And so they used this particular hospital preferentially because all the other hospitals made them do a complete H&P. And guess what? The hospital paid back $10 million and took it out on the medical staff. Sometimes nurses are hired to do H&Ps and discharge summary for cardiologists, but nurses are not licensed in the state to diagnose. So when the cardiologist comes along and signs the nurse's note and accepts just the nurse's note, that's considered fraudulent. So stuff happens. You don't want it to happen to you.